कर दी। Amit Soni. I am heading the medical affairs team here in Corona Remedies, and today on World International Women's Day, it is our pleasure to have you all over here to discuss about something which is very much pertinent, and that is endometriosis. And we are very delighted to have nothing but an expert in the field who can just throw light on everything about the management of endometriosis, keeping in mind the current era. There are some innovations in that line, and I'm sure he also will be throwing the light on that. So it's my pleasure to invite Dr. Bani Kumar Mitra. Sir is a senior gynecologist and ART expert at Surgery Center in Kolkata. He's practicing there for more than 40 years, and he's currently interested to work, which is including ART, recurrent pregnancy loss, and endoscopic fertility, as well as enhancing surgery. He has got numerous publications and has contributed various chapters into the books related to infertility. He has also given many lectures covering all over India on various aspects of infertility and ART. He has conducted 2 workshops on endoscopic surgery at Bangladesh and delivered lectures in different places of Bangladesh. He is a life member of many national bodies, which includes FOXY, ISAR, Menopause Society, and Indian Association of Gynecological Endoscopy Society. He is attending various global conferences too, which includes ESHRE as well as ASRM for last 20 years. And there are many more things to talk about Dr. Mitra, but I don't want to snatch the session from him. So, sir, with this great pleasure, I hand it over to you to discuss about all your expert and your experiences regarding endometriosis. Over to you, sir.
Thank you. Thank you very much indeed. And at the very outset, I thank Corona and Dr. Amit Soni for giving me a chance to speak on this International Women's Day on a topic which is very pertinent in women's life. The challenge of endometriosis is a menace to both the clinician as well as to the patients alike. And because the prevalence of the disease is very high, about 1 in 10 women suffer from the disease. It's present in about 5 to 10% of women in reproductive years. 80% of women with pelvic pain have associated endometriosis, and 30 to 50% of patients with endometriosis of infertility have endometriosis. Moreover, the disease affects of people, women of younger age. 64% of them are of less than 30 years of age. And it affects the quality of the life, which is very important, because that is where the main challenge is how to control the most two pertinent symptoms, that is infertility and pain. Lastly, as you all know, that infertility is associated with endometriosis, and endometriosis patients are 6 to 8 times of a higher chance of becoming infertile. The fecundity rate in endometriosis is very low, about 0.15 to 0.1% only, in comparison to the normal fecundity rate of 0.5 to 1.5%. And lastly, the disease has got a notorious history of recurrence. Almost 40 to 50% of recurrent risk is there. So that is why this disease of endometriosis remains a challenge to the physician. I gave my first lecture in ISAR, that is when ISAR was, that was the third or fourth ISAR, All India ISAR in Calcutta, way back in 1995, where I said that endometriosis remains an enigma wrapped in mystery. As days goes on, and with the advent of newer technologies, we have a better understanding of the etiopathogenesis of the disease. And now we know that endometriosis is 50% genetic and 50% environmental. And with genetic, epigenetic modifications, somatic mutations, epithelial mesenchymal transition, and some mesenchymal epithelial transition, the gut-brain axis, all these are coming into play in the etiopathogenesis of the disease. And it is now designated as a chronic inflammatory disease with a genetic background predisposed by an expression of estrogen hormones that leads to inflammatory reactions causing the symptoms of endometriosis. With this idea in background, laparoscopy was till yesterday the most criteria of diagnosis endometriosis. But today, with the advent of deep transvaginal, so widely availability of transvaginal sonography, most of the disease of endometriosis can be diagnosed with the transvaginal sonography in the clinician's chamber as mainly. Now, newer technologies are being developed to diagnose the disease of endometriosis in a non-invasive way, and particular reference should be mentioned about the MRS, measurement of MRS from the saliva, which is a non-invasive test currently undergoing trial in France, which can detect the disease of endometriosis and it forms an important screening test of women beyond 18 to 44 years of is the BCL/6 expression in the endometriotic fluid, and that leads to one of the important causes of implantation failure in cases of endometriosis. Lastly, advances in radiological techniques, mainly the MRI and especially MRE, which can diagnose the disease, not only the diagnosis, but the depth and the size and the elasticity of lesion, which helps in for future surgeries if we plan in that way. And also the radioactive level PET scans. So these are the new armamentariums which are important in the diagnosis of endometriosis in a non-invasive way. So far, as I said to you, that laparoscopy was the gold standard of treatment of diagnosis. I mean, diagnosis of endometriosis, but today it's no longer so, except in very few cases where the diagnosis remains elusive on these screening tests. Now, having said that, let's see, as you all know, we are going to mainly focus on the infertility aspects of endometriosis. And previously, in advanced stages of disease, the anatomic distortions that can cause the problem of infertility. But as light is being more and more shed, especially in case of earlier stage disease, it is being said that the endometriosis has an impact on the oocyte quality, the embryo quality, and the implantation potential of the woman. And these are coming more and more into the day as we advance in our IVF programs. So that is how it affects the quality of the eggs and embryos. But having said that, once the embryos are formed, the chance of pregnancy in a patient with endometriosis vis-a-vis patients with not endometriosis or tubal factors remains the same. However, the implantation potential of the embryo has to be checked, and the implantation in endometriosis still remains a point of challenge, and that is where the different tests, that is the ERA test or the BCL expression overexpression of BCL6 protein, is coming more and more into play. And currently a trial is undergo, which is called the EFFORT trial, which is where we actually diagnose these, correct that by giving medicines and then plan the implantation. In our experience, we have seen that if we are planning, especially IVF in cases of endometriotic patients, it is better to split the thing into two halves. Firstly, concentrate on improving the oocyte quality, thereby embryo quality, and then doing a frozen embryo transfer after correcting the endometrial factors or endometriosis-related problems. Now, there is a paradigm shift in the management of endometriosis, and medical management is more and more playing a bigger role in management of endometriosis, especially with the idea being that it's a recurrent disease, so long-term disease control of endometriosis is very important. And that is where the medical advances in medical management are coming into play. So far, the GnRH analogs injections was the mainstay of collecting thing. Of course, danazol is no longer used, but in the when it is lost in the oblivion because of its toxic hepatic effects. And the choice of medical treatment lies between the dinogestrel, which is specific progesterone, and it's more recently Elavox, which is with Euclid in the block, and the other is the traditional GnRH analogs. but GnRH analogs cannot be used for longer periods of time because of their effects on bone mineral density loss or other effects of affecting the quality of the life. So the mainstay of medical management today is between dinogestrel or Elavox. Now comparing the two, Gupta and all are did a trial where they compared about 350 patients in the control of pain management of with both the drugs and found them to be equally effective. Having said that, you all know that dinogestrel has got an effect on breakthrough bleeding and also some effect on liver function and can cause pro-thrombotic effects, which is there. Elavox, on the other hand, does not carry these effects. And the beauty of this drug is that it is an oral GnRH antagonist which blocks the hypothalamo-pituitary axis, thereby producing the change within a few days without the causation of breakthrough bleeding or irregular bleeding which occurs with dinogestrel. It causes suppression of the hypothalamo-pituitary axis, thereby reducing the symptoms of endometriosis, that is pain, and controlling the disease of endometriosis. All the aspects of pain, that is pelvic pain, dysmenorrhea, dysphagia, all are equally controlled with Elavolyx, which have been tried in different trials and has been proven to be a drug of choice in these situations. The beauty of the drug is that Elavolyx has an E2 threshold value where you start at a higher dose to bring the estrogen levels down, control the disease, and then you can titrate your dose for a longer periods for use in longer periods of time, and where you intend to maintain the estrogen between 20 and 50, thereby preventing the bone mineral density loss which occurs with injectable GnRH analogs or with prolonged use of letrozole therapy, which is also an efficient drug in control of the disease of endometriosis and adenomyosis. And so when you are using Elavox, you can start at a higher dose of 200 milligram twice daily for a period of time. Then once the symptoms are controlled, then you can reduce it to 200 milligram daily, and for longer periods of time, if you want to maintain the improvement status of the patient, then you can continue at 150 milligram daily, and you can use it for long periods of time. The available data today is up to 2 years, whereas in dinogestrel maybe a bit longer than that. So that is where the Elavox stands cut above the dinogestrel or the traditional GnRH analogs, that it can be used for prolonged periods of time with a titrable dose, maintaining an E2 threshold value to prevent the bone mineral density loss. We start with 200 milligram twice daily, reduce to 200 milligram daily, and then 150 milligram daily for maintenance dose. The side effects of the drug are very minimal, except some amounts of hepatic impairments. It can cause, if you use at a higher dose for a prolonged period of time, then it can cause more BMD loss, and it is contraindicated when certain drugs are used. The drug can be used in any patients with complaining of pain, menstrual pain, or dysmenorrhea or dysmenorrhea, without even being proven that it is because of endometriosis. However, some amount of proof is beneficial. The other area, this is for pain relief, where what we find interesting about Elavox is that it can be used as an alternative, whether it can be used in cases of infertility, as an alternative to the injectable GnRH antagonists that are used in controlled ovarian stimulation protocols, and it is being tried for that purpose. Today, it can be used from when the leading follicle reaches 40 millimeter. You can use the oral antagonist drugs for a period of time till the ovum pickup is done. And so there you can use a dose of 200 milligram twice daily or 200 milligram daily or even 150 milligram, depending on the age of the patient, the number of follicles that are coming up, E2 values. So that is how you use the drug. Of course, this learning is still going on, and a lot of trials are being conducted in this field so as to prove its efficiency in the in comparison to the traditional GnRH, injectable GnRH antagonist, in order that you can reduce the painful load of injections to the patients, and it can be more convenient for the patients to use the drug with a lesser amount of injections, and also reducing to some extent the cost. So that is one use where the GnRH oral antagonist can be used in cases of stimulation protocol in IVF. The other thing is that you can continue the drug after the ovum pickup to prevent ovarian hyperstimulation syndrome. In cases of polycystic ovary, you can continue the drug for a period of time so that the ovarian hyperstimulation syndrome does not occur, and you can downregulate the hypothalamic pituitary axis in order to prevent OHSS. So that is an advantage of the oral antagonist for prevention of OHSS disease. Thirdly, in cases where I said to you that in cases of where implantation failure or pregnancy loss has occurred in case of endometriosis, you can measure the endometrial BCL overexpression, and it has been, if you can find that this is there, this actually affects the endometrial proteins, which are very crucial for the implantation fetus. All of you are aware of the fact the window of implantation, where there is maximum amount of integrins and other important factors that are secreted in the endometrial fluid, which are very crucial for implantation and to reject implantation. So that is where if you give a pre-treatment with oral antagonist drugs for 2 months of time, then downregulate the axis and then prepare to do endometrium in a controlled way and do a frozen embryo transfer, then your chances of pregnancy may increase. And a trial is going on, which is the effort trial, which is being done at the moment to prove that. The other thing where this drug can be used is in cases of control of adenomyosis for a prolonged period of time. You control the uterus, the adenomyosis, control that, and then you do your embryo transfer so that the chances of implantation is increased. So that these are the different areas where in cases of infertility or ART practice, you can incorporate this drug in order to improve your chances of pregnancy. Lastly, this drug can be used if you are planning to do a surgery. You can use the drug for a period of time before you contemplate the surgery, so as to control the disease, make the surgery easier. Then you do your surgery and choose your line of treatment. At the present moment, this medically assisted reproduction forms the mainstay of infertility management in cases of endometriosis. Surgery is indicated definitely in some cases where these big chocolate cysts or these chocolate cysts obscure your paths of ovarian outside retrieval, or in cases of deep endometriosis where you have to resect the lesions to make for pain relief in order to desired comfort level of the patient. However, excision of deep endometriosis doesn't increase has got much more distinct role in improve the chances of pregnancy, but is definitely indicated in cases of pain relief in particular situations. So the mainstay of treatment of endometriosis nowadays is medical treatment, and you can use the drugs for a long period of time to control the disease, and you can plan your fertility treatment accordingly depending on the age of the patient, the antral follicle count, the semen factor, tubal factor, and the endometrial fertility index. So these are the different things on which your whole treatment of infertility will depend, and you can plan your treatment accordingly. In cases of mild to moderate disease, you can do controlled ovarian stimulation with gonadotropins and letrozole and do intrauterine insemination, which gives an equal result or comparable result as in cases of unexplained infertility. Surgery should be reserved for those cases, as I said to you, where there is deep endometriosis or in case of larger lesions, to correct the surgery, and your surgery should be done only once, and that should be done in definitive surgery and by experts, where the main aim is to restore the pelvic anatomy restrict your damage to the ovarian tissue, conserve the ovarian tissue in order to improve the fertility. In very young patients with mild to moderate disease, some cases of stage 3 disease, after doing the surgery, the chances of spontaneous pregnancy improves, and that effect usually lasts for 6 months. And you can couple with that with intrauterine insemination, or depending on your other factors, you can plan your IVF. The other way it can be done is that your medical management of the disease, a wash-up period of about 2 months, followed by controlled ovarian stimulation and IVF, and then after achieving the desired pregnancy, you can plan your definitive surgery if that is needed. Lastly, the need for long-term prevention of recurrence of the disease is very important, and especially to avoid recurrent disease when it occurs. Instead of doing a surgery, you can plan your medical management and do that surgery. Do the control of the disease with the medical treatment for a prolonged period of time. Lastly, the IVF is coming in a bigger way in the management of endometriosis, especially in relation to infertility, because of the fact that the disease affects the quality and the quantity of the eggs and also the implantation. That is why IVF is assuming a higher role in terms of fertility treatment as then during the yesteryears. So, ladies and gentlemen, it's a time for change in order to achieve or improve the quality of the life of the patient, to diagnose the disease early, because the diagnosis is quite late, and it is diagnosed only at a later stage. That is where the non-invasive tests are coming into play to diagnose the disease at an earlier stage and plan your disease to prevent and to control the disease and to prevent the recurrence and to produce the desired effect of fertility, be it either by medical assisted reproduction or by IUI or by IVF, whatever it is. So with these few words, I would like to open the platform for questions and answers, and I can join in answering those as to the extent as I know and have my experience about that. Thank you very much indeed.
Thank you, sir. Thank you so much. And this indeed was extremely enriching session, or I would say enriching information regarding conventional to the latest mode of managing endometriosis, and the way you thrown light on the novel agents and the usage. That probably is something really, really very informative. We are getting questions from places, and I would like to share those questions. Probably part of it might be covered during the session, but people are still have asked this question in between the session. So please respond to them and enlighten with your experience, sir.
Yes, sir. As on my part, time is a bit restricted, and I have some other commitments to do. So I would take 3 or 4 questions, and other questions you can share with me later on, which I will answer by mail or by other means, so that it can be conveyed to the participants.
Perfect, sir. Perfect, sir. Got your point. So we'll be restricting to the time wherein we'll not be deviating your commitment to. So, sir, one of the question which has come is that what is the incidence of recurrence after the endometriosis been treated with elagolix? Have you experienced the incidences of recurrence after the complete treatment of, say, or rather I would say a treatment of elagolix for 2 years been given in endometriosis? That is what is the question.
Yeah, endometriosis actually is a recurrent disease. Once the ovulation occurs and the estrogen comes into play, there is always a chance of recurrence. We have seen recurrence even after patients have their child, and patients are having a child coming back with the recurrent chocolate cyst after even 5 to 10 years of childbirth. To the later ages also, we have come quite a few of these patients. And there you actually plan your definitive treatment depending on the age of the patients, depending on the symptoms. You can give a pre-treatment with medical treatment once again to control the disease, and they plan your definitive treatment according to the patient's age, choice, and need.
Okay. Thank you, sir. Another question is that if the patient who is on elagolix suffering from hot flushes, what would you recommend to those patients?
Sorry,
If the patient on elagolix, endometriosis patient on elagolix,
Yeah.
suffering from hot flushes, what is your recommended treatment for that?
Actually, you lower the dose. You measure the E2 level, see what is the E2 level. And depending on that, you lower your dose, which suits the patient and then which takes care of the hot symptoms of hot flush.
Okay. Another question is regarding, I would just take it as the last question, looking into the time. Sir, what is the incidence of amenorrhea with elagolix that you have observed?
The incidence of amenorrhea with elagolix is dose dependent. When we first was using the drug, I have an experience of using the drug for about 2 years, especially on patients from Bangladesh where the drug was licensed to use. We were initially using it 150 milligram per day, and that is why we were encountering some breakthrough bleedings in these cases, and some periods were occurring. So later on, when these cases on lower doses had breakthrough bleeding, we are now starting at a higher dose of 200 milligram twice daily. Then after the down regulation, we are bringing it down to 200 milligram daily. So in order to maintain the E2 level to your desired own level, that is between 20 and 50, depending on what you want. If you want a long-term treatment for pain relief, you maintain the dose between 30 to 50. If you want a treatment for infertility or down regulation, then it should be around 20. So depending on your need, you tailor your dose, and that is how you can control the problem of your bleeding with elagolix.
Okay. Okay. So, sir, we have got a few more questions, but we'll write it to you separately post this session.
Sure.
We'll look forward for the answers, and we'll be sharing it to all the eager audience. And thank you so much, sir, for your wonderful session on this. And we are really feeling very pleased to have you on this day of World Women's Day, wherein we are just trying to put in an effort to increase the happiness in the woman's life by spreading the awareness about something which you said so prevalent but not so well addressed as a medically managed condition. So thank you so much for your wonderful talk and the support, and I thank you on behalf of Corona Remedies. Thank you so much, sir.
Thank you very much for giving me a chance to speak on this auspicious Women's Day, and I find myself privileged to share my views on this topic, which might improve a lot of young women's life, because as a more and more endometriosis is being diagnosed in younger women in the peripubertal age, in the adolescent group. Thank you very much indeed.
Thank you so much, sir. Have a good day. Bye-bye, sir.
Thank you.